people in the room if there's more than one, and your organization. That helps us. And we're going to just start introductions with the folks who are here. I'll start here at Wayside Business Office. I'm Rebecca Buller, and with me, Elena Forrest Perkins. And also in the room, we have Sarah Curry, our ECHO coordinator, and James Curry. Sorry, and James, our IT professional, who keeps everything running. So let's go to Cheryl Hansen and have you check in. Cheryl, okay. If you are able to unmute and join us with audio, let us know. Let's go to Jessie, please.
Hi, Jessie Evers from Wayside Recovery Center, and Finn is here in the office with me too.
Okay, great. We're not going to do Fallon. She just walked away. Let's try. Oh, there's Fallon. Fallon, would you like to check in with us?
Hi, can you hear me okay?
Yes, we can.
Okay. Hello.
Welcome.
Thank you.
And let's see, we have Chelsea Knoll.
Yes, hi, I am here.
And Chelsea, what organization are you with?
I am with Mothers First in Ramsey County.
Wonderful.
Yeah.
Paku? Is Paku there?
Yes.
Wonderful. And you're with which organization, please?
Paku is with Mothers First. She's having some technical difficulties, but she's here.
Good. Thank you. Let's try Dr. Grahan. Brian, would you like to introduce yourself? Brian? Okay, he's working on something there. Let's go to Nelda Goodman.
Say hi. Hello.
Hi, Nelda. Are you on with us?
Yes, we are connected.
Wonderful. Is there anyone else with you? We don't have a picture.
I'm leaving.
I don't know how. We just got this picture up.
You don't have a
Oh,
camera.
I don't have a camera and I don't have a microphone.
Well, you're doing quite well without. That's good.
Okay, it's all on the phone.
Okay, that's good. Let's see.
Okay.
Dr. Grahan, would you like to introduce yourself now? Hi.
Hi, I'm Brian Grahan. I'm one of the physicians at Hennepin Healthcare.
Thank you so much. Has anyone else joined us?
Cheryl.
Cheryl Hansen?
Yep.
Would you like to introduce yourself, please?
Oh, I'm the public health nurse at Mothers First in Ramsey.
Wonderful. Thank you so much.
Uh-huh.
Well, welcome everyone. We're going to get started because we have a very wonderful and meaty presentation, didactic or lesson for today. Thanks to Dr. Grahan, and the didactic title is Medication Treatment for Opioid Use Disorder. Hopefully you all have the slides that came in the PowerPoint that was emailed out earlier today. And then when he's wrapped up, we'll take questions and then move on to our case study. I think that's everything for right now. Again, don't forget to sign in the chat area. And Dr. Grahan, are you comfortable taking over at this point?
Sure, I'm just kind of pulling. Do you want me to just share my screen, or do you want to, how do you want me to do it? I'm happy to do whatever.
Why don't you share your screen? That would be best.
Okay. I am just pulling it up right now, so I'll have it in just a moment.
Thank you.
My computer failed a couple days ago, so I got a loaner, so I'm just trying to pull everything together right now.
Oh, I'm so sorry.
can you, here we go. Can you see that?
Oh, we can see that you've started sharing your screen, but we can't see the slide. There we go. We've got them.
Got it?
Yes.
All right. So again, welcome everybody. My name is Brian Grahan. I'm one of the addiction specialists here at Hennepin Healthcare. My background is in both internal medicine and pediatrics, although right now I'm primarily practicing internal medicine, largely because I think about families more as the unit of care for the kids. But that's a topic for a different discussion. Today I'm here to talk about primarily medications for opioid use disorder. There's a lot of detail and meat that we can get into. This is going to be pretty much an overview, so please feel free to have questions. I'm going to be kind of going through all this at some pace, please jump in at any point in time. As you know, this is all these things are funded through DHS, but otherwise I have no other financial interest. Some of the slides were adapted from a program developed a year or two ago, but I've kind of updated and revised a lot of them. So my objectives for our brief time together is really just so that you feel like you can list the medications that are approved for the treatment of opioid use disorder, and then just describe how each medication can play a role in improving treatment outcomes for your patients who deal with this disorder. I think it's helpful just to kind of start from the get-go of like what's the role for medications. In general, I think it's just mindful when people first start using, that's when they describe that high, the feeling. And then over time, and there's lots of kind of neurochemistry underlying this through their own endorphins and their dopamine reward system kind of gets suppressed. And so people will feel this depression, and after a while they stop using to get the high, they just start using to just try to feel normal and not horrible. And it's really correcting, as long as they kind of have these big ups and downs, their ability to recover both from a depressive state as well as to feel the normal amount of reward or pleasure they get from normal day-to-day activities like exercise, relationships, all those day-to-day normal things that we take for granted, oftentimes requires some degree of stabilization, and that's what the medications are there for. It's just to try to minimize this up and down, because it's actually the up and down is what our bodies respond to, and that's what suppresses kind of our ability to feel all the other normal things. So finding that stable state to allow therapy and other things to kick in is a lot of the goal of medication therapy. So in the absence of medications, what are the outcomes? And this is specific to opioid use disorder. I think historically all addictions got lumped into one. It's really clear now that opioids is a different beast. In most studies, there's at least an 85% relapse rate without some sort of medication assistance when you're talking about opioids. So in this one study, the prescription opioid agonist treatment study, they did a period of 2-week stabilization followed by a 2-week taper, kind of a very common detox protocol for about 600 some patients, and there's a 93% relapse. After that, they said, okay, well, let's just get them on 12 weeks stabilized on buprenorphine, or the most common brand name of buprenorphine is Suboxone. Then they got about 50% people abstinent by just 3 months on buprenorphine. They said, okay, now that we're stabilized, we'll do a slower taper now, because that's oftentimes how people think about treatment is kind of this like stabilization, then kind of a slow taper. So they tapered over the course of a month, and within about a month after that, then 91% had relapsed. So that was kind of the primary study. Then they got funding, however, to follow people up 18 months and actually 30 months and then 42 months after. So they followed people for 3.5 years afterwards, about half of the people that were in the study. And all of them were just offered open label. If you want to be on medication, or specifically buprenorphine, then feel free. And this is kind of the outcomes that played out. So the graph is a little confusing because abstinent from prescription opioids includes those people that were on agonist therapy and the people that were not. So sometimes it's a little confusing to interpret the graph, but the numbers tell the story. About half the people were abstinent from illicit opioids at 18 months. Those people that were on agonist therapy or buprenorphine had an 80% success rate. Those people that had no medications, it was about 1/3 of the people were successful. Similarly, at 3.5 years down the road, 60% of the people were abstinent. There, this is a little different in the prescription opioid group compared to those people that are using heroin. Again, 80% of the people that were on agonist therapy were successful, and about half of those who are not on medications were successful. So what happens if you include opioid or IV opioid use, whether it be heroin or fentanyl? Here the numbers tell a different, slightly, it's a similar although more bleak contrast. Here again, when you're on buprenorphine, at intake everybody was using. If you're on buprenorphine, you've got a much higher success rate of either illicit opioid use or IV drug use compared to treatment as usual without any medication. And you can kind of see in the graph there, it was a stark difference. And then here, when you include in this other trial, about 2/3 of the people were on IV heroin or fentanyl. Now you can see either with methadone or with buprenorphine, you have a massive reduction over the course of 5 years total in terms of how well people do. So, needless to say, relapse opioids without medication is about 85% plus in the short term. If you're on prescription opioids with no history of IV over the course of years, about 1/3 of the people become abstinent without any assistance. 1/3 are able to maintain when they're on medications, and oftentimes the people that are abstinent are years out, started on an agonist therapy and then phased out, and then about 1/3 of people are continuing to use. When you're on IVs, this is really what the number you're thinking about. So medications have a huge option, and here's really what the options that you have in front of you right now. So one, full agonist therapy is methadone. Kind of the partial agonist for an opioid is buprenorphine, and then the antagonist is naltrexone. There are pluses and minuses to each of these that I'll go into in a moment. So medications for opioid use disorder: methadone, buprenorphine, naltrexone. I just listed the brand names because I think oftentimes you hear those far more often than the generics. Suboxone, Subutex, Zubsolv, Bunavail are all transmucosal, are oftentimes described as sublingual or under the tongue, or dissolving in your cheek. There's now an implant that's kind of like Nexplanon. It's like a little cartridge that you can kind of put on the inside of your arm that is the equivalent for about 8 milligrams of buprenorphine. Not very common in the metro area or even nationally. It hasn't gotten very much uptake. Just a couple months ago, there was a new subcutaneous injection that you can do that also lasts for a month called Sublocade. And there's another subcutaneous product that's just been submitted for FDA approval this month that's pending, that has both a weekly and a monthly option. You also have naltrexone, the oral version of which is the brand name is Revia, and the intramuscular depot injection that lasts for 4 weeks is called Vivitrol. So methadone first. This is the oldest one. Originally developed in the 1950s. Major studies started coming out in the mid-1960s. Has a wealth of data behind it. It both still arguably the most effective treatment in many arguments, depending on the outcome you're looking at. It increases survival, has slightly better treatment retention than buprenorphine, and definitely better than naltrexone. Improves employment, decreases illicit opioid use, infections, criminal activity, a wealth of different benefits from methadone. It's highly regulated and dispensed through opioid treatment programs. In the state of Minnesota, they used to be considered Rule 31 programs, but for medication therapy. Now they're the 245G. And for those that you may or may not be familiar with what that means, is that when people go to a methadone program or an opioid treatment program, it's a daily liquid administration. If somebody's on methadone and goes to one of your programs, from a residential program or even it'd be residential, then they would kind of have to come through a chain of custody with liquid doses with them. But when they're not in a program, in a residential program, then they just have the take-home doses in a lockbox that they get home. In order to even have a lockbox and takeouts, they have to be stable for at least 3 months, and each kind of period after that, as long as they have negative urine drug screens except for the methadone, then they can kind of get a day each. So in order to get one marker of stability for people is asking how many takeouts they have, and that can kind of give you a sense for how long they've had negative urine drug screens for other medications aside from methadone, and how consistently they've been showing up to the program. And each of these programs will have counseling In urine drug testing, the max ratio of counselor to patient is 1 to 30, but oftentimes it's more closer to 1 to 20 or 1 to 25. However, in many programs, other psychiatric medical services are not provided. There's some exceptions here at Hennepin Health. The opioid treatment program that we have has psychiatry services on staff. And so every Wednesday there's a psychiatrist there. Other medical care is generally not as consistently available. And it's illegal for other providers to prescribe methadone for the purposes of an opioid use disorder in general practice. That said, you may hear about other people being on methadone for pain, even though it still has significant risks that I'll explain in a moment. So you saw in that first graph, methadone is a full opioid agonist, means that when it binds to that, it's called a mu opioid receptor. There's a couple different types of opioid receptors in your brain and throughout your whole body. But when it binds that mu opioid receptor, the more you get to it, then the bigger kind of the effect on that receptor, which is different than buprenorphine, which only partially binds it yet still blocks it, which is, I'll get into the reason why that's important in a minute. The onset for methadone is usually kicks in between 30 to 60 minutes. The half-life ranges from 18 to 50 hours. And so that's one of the big reasons why dose changes for methadone is very slow, because you can, if you adjust the dose quickly, then it can build up in somebody's system, and that's when they have complications. Because you can increase the dose every day for a week, and suddenly they actually have, instead of just slowly going up every day, having their dose change, because it builds up over the course of a week, missing 2 doses in a week can actually have the equivalence of like a 15% dose reduction, just because they missed a couple doses, sometimes even greater depending on the person. About 20 to 40 milligrams of methadone will usually relieve most acute withdrawal symptoms, but it requires about usually somewhere 60 to 80 or sometimes higher to extinguish cravings. And at a high enough dose, even if you were to use another opioid, you wouldn't really feel any of the euphoric effect if you're on a reasonable or a high enough dose of methadone. People that say they get it for pain, unfortunately, the hard part is oftentimes this is a very common misconception because people know about methadone programs, but they don't understand the medication. So oftentimes patients get referred to have chronic pain, saying maybe you should just go to a methadone program. However, the pain relief or the analgesic effect for those people for whom opioids are going to help their pain only lasts for about 5 to 8 hours on methadone. So the full duration of the effect of craving suppression can be that 18 to 50 hours. But actually the pain relief effect is only 5 to 8. So there's different dosing for pain compared to addiction. And methadone unfortunately has a lot of different medication interactions, especially with different psychotropic medications that are commonly prescribed for folks with addictions. And so just kind of a brief comment, duration of therapy, oftentimes people think of just detox. Detox has no long-term effect on outcomes. Oftentimes, if anything, it worsens your outcomes because then you lose any tolerance and the likelihood of overdose is higher. But oftentimes longer duration or higher dose treatment, the average treatment for people that are successful is around 80 to 120. It's fairly unusual for people to need more than 120. That said, I know there's lots of community programs that dose higher. Part of the reason for that is the way that opioid treatment programs are structured. By federal statute, each counselor is mandated to ask kind of 11 different specific symptoms. And that's kind of what the initial survey is for what people report as to withdrawal symptoms. Many of those symptoms oftentimes cross over with what people report as feeling for high anxiety. So it's very easy for patients to conflate withdrawal symptoms with bad anxiety. And sometimes without appropriate oversight or other intervention and screening, people can then get their dose higher when they're not complaining about withdrawal, they're actually complaining about anxiety. So oftentimes you'll see doses of like 150 or higher even. And oftentimes those people are feeling fairly sedated. For some patients, therapy may actually be lifelong. For people with a really severe opioid disorder, given the relapse rates that we were talking about, even when you try to do a very slow taper, sometimes people's reward systems don't respond and they just stay dysregulated. And for those people, many times lifelong therapy just means that they have a normal life after that, aside from the fact that they're on methadone. So again, one of the common things that we see in an opioid treatment program, and one of the staff here for our own opioid treatment program, is if somebody's on methadone, usually whatever happens to them is blamed on the methadone because it's so often misunderstood. So you'll see all sorts of things but yet appropriately dosed methadone, people should not be over-sedated. They should not be nodding out a few hours in your program or at their job site. They should be safe to be driving. It reduces relapse, it improves pregnancy outcomes. They can have normal, very healthy lives. Switching topics then a little bit back to the buprenorphine. The difference between this and methadone is it's a partial opioid agonist, which means it binds that same receptor in the brain and throughout the body, but instead of the more you get, the higher your dose goes or the higher the effect, really has this ceiling effect that I think I have coming up here again. So here you can kind of see your maximum dose, you pretty much saturate all your opioid receptors around 24 milligrams. You might get a 2 to 3% benefit going from like 24 to 32 milligrams. The most insurance providers and most medical literature would support the fact that you really, really ever, if ever, need to go above 24 milligrams of buprenorphine. And one of the benefits to buprenorphine is it has very few drug interactions, just the nature of it. Similarly, or kind of in addition, when it binds that opioid receptor, it binds very tightly. Methadone, lots of different things can kind of affect it. So as you're going up on your dose of methadone, if you take fentanyl, oxycodone, pick it, then you can still get additional euphoria on top of it. So you'll oftentimes hear people talking about at lower doses of methadone, they still keep using until they get a high enough dose of methadone. Buprenorphine, as soon as you have about 4 to 6 milligrams, when you use any other opioid, you pretty much won't feel any effect. You might get a little bit of a pain relief effect, but you won't feel any euphoria on it. So oftentimes you get a significant blockade of any other benefit just on a relatively low dose of buprenorphine. That said, because it has that tight affinity to the receptor so that everything else gets kicked off, you have to be really careful when you start somebody on it, because if somebody took oxycodone, a few hours beforehand, then you start them on a low dose of buprenorphine, the buprenorphine will kick off the oxycodone, but that will also put them in a pretty severe precipitated withdrawal. So they'll have an acute withdrawal. So before people can start on buprenorphine, they have to be in mild to moderate withdrawal. For heroin, that's about 12 to 14 hours afterwards. For oxycodone, that's usually about 18 to 24 hours. And for longer acting medications, it can be longer. So for like methadone, oftentimes it's at least 48, oftentimes 72 hours or more before they're ready to start on buprenorphine. Oftentimes it's combined with naloxone. That's what Suboxone is it both buprenorphine with naloxone. The naloxone in Suboxone is not biologically active. It's actually bound up in these microbeads. And the only reason naloxone ever has any effect is if the person tries to crush it or liquefy that medication and inject it, then the naloxone would then dominate the buprenorphine and they would have withdrawal instead of any euphoria. So the naloxone is there only as an abuse deterrent. As I mentioned, there's 3 different formulations for it. Some places will start people in their clinic. However, many people have gone to just home inductions. Oftentimes people have already used it on the street for their own purposes. So oftentimes home inductions have been very safe and effective for people. Here's just kind of a summary that you can kind of look at your leisure. Buprenorphine, because it's a partial agonist, has a lot less sedation associated with it. It has a much lower risk of respiratory depression, yet there definitely have been deaths when people have overdosed on benzodiazepines or heavy alcohol use combined with buprenorphine because it still is a potent opioid. That said, it's much safer than arguably any other opioid that's out there. And we kind of reviewed this. So then kind of the final thing is that naltrexone, kind of on the flip side of, instead of even partially agonizing and dealing with the cravings and that maintenance, they're kind of getting to that steady state that allows people to kind of normalize their reward system. The flip side is going to naltrexone, and this just kind of shows that people are very successful on that office-based Suboxone. Oftentimes 50 to 80% success rates, which is, compared to any other medication out there, phenomenal. I think oftentimes people say it's only 50% effective, but compared to most medications, that's fantastic. And it definitely reduces overdoses. This is data from Baltimore. One thing I'm glad I put this here is to remind myself, one common question around where methadone is fairly highly regulated, but even people that get takeout doses, when they get it, they'll get like a bottle of liquid methadone. liquid methadone is definitely diverted and can be used for abuse because it is a full opioid agonist. So people can get some euphoria off it, especially combined with cocaine and other street drugs. Buprenorphine is actually interesting though. It's rarely, very rarely ever used for euphoria. About 85 to 90% plus of the buprenorphine that's been diverted to the street in multiple different studies have actually been found to use it for similar reasons to what you'd use it for in a clinic. People are trying to not have withdrawal and kind of stabilize their lives. So I've had a number of patients that have come in seeking care with me that have already had, part of the reason they're coming to me is the best they've ever felt is the 3 weeks that they were on, that they bought Suboxone instead of heroin on the street, and they liked that few weeks of stability they had 2 years ago, and they wanted to come back and really when they kind of wanted to stabilize their lives. So you can see the great majority of why people are getting it is really very similar to the same reasons that they'd be seeking Suboxone in a clinic. Naltrexone, as you kind of saw in that graph, goes the other way. It says we're just going to block any effect of the opioid receptor. So because it's blocking everything, there isn't any physical dependence or withdrawal from it. And in fact, if you are on chronic opioids and you start taking naltrexone, you get that precipitated withdrawal because it kicks everything else off the opioid receptor. This doesn't require any added training, so any doctor anywhere can start giving it, although the injectable naltrexone is quite expensive, so oftentimes health systems will limit who can get it. And it can be difficult for some clinics to get that first few doses, although there is a state grant that's available that you can get a couple of the first doses covered through state funding to get somebody established on the medication. Arguably, there's actually much better evidence to say that Vivitrol or naltrexone is more consistently effective for alcohol use disorders than opioids. You may hear people talking about naltrexone in both contexts. As I mentioned, there's both oral and the injectable formulations of naltrexone. The oral versions of naltrexone have only ever been shown to be effective for opioid disorders for people that are in highly regulated, high-cost programs. So like 2 years of very close monitoring for like pilots or healthcare professionals. In those specific instances, the oral naltrexone has been helpful. In no other study has the oral naltrexone been found significant for people with an opioid addiction because there's not enough close monitoring, and if you just decide one day that I'm not going to take it, then there you are. So there's a lot less data in support of oral naltrexone for the use for opioid addiction. That said, there's increasing data saying that the injectable depot formulation, because it takes choice out of it and just says you're on it for the next month, there's been a lot more benefit shown for that. The hard part has been getting people abstinent long enough in order to establish on the medication. So it requires, depending on what you're reading, kind of by the manufacturer's label, it says you require 7 days of opioid abstinence prior to initiation, which for many people with a severe opioid disorder is way longer than they've ever been off of it. Usually people can tolerate like a day, maybe 2 off of it. But it's rare that they can tolerate that long off of their opioids. So this has been one of the major challenges facing this as a therapeutic option of who's going to be stable and abstinent long enough. That said, for the first time ever, just a few months ago, the data got released, the very end of 2017 got released on the first 2 comparative trials of buprenorphine or Suboxone, and it was Suboxone was the product that was used in the study, compared to Vivitrol, this intramuscular depot naltrexone. There was one study that was done in Scandinavia and one study that was done in New York and a couple other sites. There were 6 sites across the country. And essentially showed that, again, what everybody's already struggled with is really getting people on to Vivitrol in the first place was the hardest part. So they had a 30% dropout before induction ever happened for the Vivitrol compared to essentially 5%. For Suboxone. So it's a much higher uptake rate of medication for the sublingual buprenorphine. And nearly all the induction failure, essentially, as we showed before, if you don't get on the medication at all, then you're going to relapse. So it's a 90% plus relapse rate for those people that didn't get on one of the 2 medications. Interestingly, though, once people were inducted on it, they actually had similar effect for up to 6 months. So this is one of the first studies that formally designated it, so there's lots of structure around that. So people were in usually residential programs when they were getting started on this. All the patients that were in this study were formally, they they're already committed to getting treatment through a detox. They were already expecting to go to treatment. So they went through a detox. If they were able to get through the detoxing and started on the Vivitrol or whichever medication, then they went on to a residential treatment and kind of that treatment course of residential to intensive outpatient to outpatient. So a fair amount of structure going through that. So in those cases, they had similar effects for about 6 months out. And the overdose, and interesting, the overdose and other serious adverse event rates didn't differ in that 6-month time frame. In other data that we have in our institution, people that are presenting for like overdoses to the hospital, we've also, in some cases, tried to start them on Vivitrol, and there's been a different set of studies that have shown anecdotally, if you start somebody on Vivitrol because that's their treatment preference, but without lots of structure around it, the likelihood of uptake of the second dose of Vivitrol is only around 10 to 15%. So it's a very low treatment uptake, and that's in claims data following people from first injection to follow-up injection. So I think in the absence of lots of structure and treatment programming around them, the likelihood of people continuing on Vivitrol is still, I'm skeptical and concerned about that. The other thing that this study is really interesting about is that one of the fears within the addiction treatment community has been if you start somebody on Vivitrol, one of the issues with that is then you zero their tolerance. And so if they do relapse, the likelihood of an overdose at that time is much higher to have a serious consequence with the relapse compared to if you were on buprenorphine or methadone. So those are kind of the concerns related to it. I think this data is making people think a lot harder about like maybe this is a reasonable treatment option for folks. And here's the data that I just mentioned. Per protocols, if they actually got on the treatment, then how did it play out for them? And here you can see kind of everything was generally equivalent between the buprenorphine or naltrexone, or both the Suboxone and the Vivitrol for people once they were able to get on induction. And the failure was really at the very left-hand side and were they able to get onto the medication. And then finally, just to make a note, because this is a really important thing, and I don't know if you have this in your programs or handy for you, is just making sure that people have naloxone, or now the most common name is Narcan, but there's a variety of different products out there between generic naloxone, the Evzio product, Narcan is the nasal spray now, but in terms of having that available for people, both for their friends, their family, or the patients themselves, to have it in case an overdose does occur. We're fortunate in this state that about half the states now have laws that allow you to prescribe to a third party. So if even a family member comes in or somebody off the street can come in and just ask, hey, I would like some naloxone. Many pharmacies are available to do that. So any Hennepin pharmacy can do that. Most Fairview pharmacies can do that. I'm not sure Health Partners is committed to that. CVS said they did, but the experience for many people is that it's not consistent from pharmacy to pharmacy at CVS if you can pick up naloxone kits from there or not. But essentially it's the overdose reversal. So many EMS providers, all police, all have them available in case of emergencies. So I'll pause there, that was a lot. Questions that people have?
Brian, you talked about pregnancy and methadone, but can you talk about the other medications you mentioned in pregnancy and other considerations you might have for a pregnant woman?
Sure. So there's one study that directly compared buprenorphine to methadone called the Mother study. There's been a number of studies off of the initial one. Essentially, the moral of the story for pregnancy is, well, first off, big picture, there's been great data studying methadone and buprenorphine. There's been no studies studying naltrexone. I think oftentimes, anecdotally, I've heard many people ask, well, don't you want to get people on naltrexone because it blocks them from having any of their opioids so the baby can't be affected? The interesting question, though, is one from developmentally. We actually have no idea what happens if you block somebody's opioid receptors during development. We have no idea what the implications for that fetus's normal development would be, or how that would play out from their own brain development. So I actually think it's much safer right now to go through buprenorphine or methadone, because naltrexone, we really don't know what it means to completely block a whole set of receptors for the majority of a kid's development, or one of those critical periods. So I'll speak really just to buprenorphine and methadone, because naltrexone is still completely unknown, and I think there's some reasonable worries about that. For methadone and buprenorphine, the two kind of main outcomes that I think about, I guess three, treatment retention, the likelihood and the duration of neonatal abstinence syndrome, and then kind of birth weight and other kind of markers of development. So if you're talking about treatment retention, both methadone and buprenorphine have a fairly high treatment retention, 60, 70% plus. In those cases, methadone actually had a slightly better, about a 10 percentage point better treatment retention compared to buprenorphine. A lot of that has to do with the structure, but also because it's a full agonist, oftentimes people feel like at appropriate dosing that they do have less cravings than they do even on max dose buprenorphine. So methadone has a slight benefit compared to buprenorphine in terms of treatment retention. If you're talking about the likelihood of needle absence and the intensity of it, in that case, actually buprenorphine has a slight advantage compared to methadone. Interestingly, the doses of either methadone or buprenorphine have no significant predictive ability of the likelihood of neonatal abstinence. So you could be on 40 milligrams of methadone, or you could be on 90 milligrams of methadone. In both cases, you could have a methadone withdrawal syndrome for a newborn. There's really no good predictor of what, well, actually, I should say the best predictor of the likelihood of abstinence in those kids is not the dose, but actually the likelihood if the mom's smoking or if the mom's on other medications that can cause withdrawal symptoms. Buprenorphine is the same. The dose, it could be 4 milligrams or 20 milligrams, it doesn't matter. So oftentimes, expecting mothers have come in and saying, like, I want to be in the lowest dose possible because I don't want this to happen to my kid. Not the point. It's not the predictor. It's really stable mom means stable kid. In that case, then buprenorphine, because it's only a partial agonist, has a slightly shorter and less intense withdrawal period, both for the newborn. And so the length of stay at a hospital and the intensity of the symptoms are significantly less for buprenorphine compared to methadone in that case. Similarly, birth weight and other kind of early markers of pregnancy outcomes seem to be slightly better for buprenorphine compared to methadone, although the data on that is not as strong. And in neither of those cases, unfortunately, most women that start out and are on either one of those medications during the course of their pregnancy, the likelihood of follow-up ongoing is really low. Right now, most published reports are only around 20%. So oftentimes that post-pregnancy period is a really critical period for trying to engage women in follow-up care, especially given the strains around kind of early mother and early familyhood periods. So that's actually a big area of research and clinical focus for lots of folks right now.
That's great. What I'd like to do is suggest that we go on to our case, and then if we have time, we'll do some more questions afterward. But I'd like to have Fallon be on our screen and maybe have you pull down your slides and stop sharing for a sec. And we'll have Fallon go ahead and present the case from Mothers First. Fallon?
Hi, can you guys all just see me, or do you want me to be the main screen or no?
Yeah, we want to see you and hear you.
I'm trying to share, but it says it's disabled. My screen?
I can see you.
Oh,
How?
Okay.
I'm checking in. It looks good.
Okay, sounds good. Okay, so the client that I'm presenting has a long history of heroin use. She's been on medication-assisted therapy for about 3 years on and off. She tried methadone in the past, but was unsuccessful on the methadone program. In 2017, she began Suboxone while at St. Joe's. Shortly after that, she became enrolled in the Mothers First program. Currently, she's on Subutex because she's 5 months pregnant. She's struggling pretty significantly with her mental health at this time. Some of the other things that are going on with her is, fortunately, we were able to get her into housing. She moved in, I believe, in May. However, working her CP plan, she's starting to reintegrate the kids back into the home, and that's caused a lot of stress, especially with trying to move, get the schedule complete, get a schedule for her kids, get her house together, manage this pregnancy. So just a lot of different things going on for her. Her main reason for seeking out Mothers First was to help get her children back through child protection. Her diagnoses are opioid use disorder, anxiety, and PTSD. Currently, the things we are working on are avoiding illicit drug use by taking your dose daily, accessing mental health services through her housing program, and preparing for the upcoming child. So some of the things right now, she's in individual therapy. She is at supportive housing through Solid Ground in White Bear Lake. And then she works with us. Her and her significant other, who is also the father of her children, are together, but a majority of the relationship prior to them being sober was they were using together. So her and I talked about the possibility of getting into some couples therapy to try to learn how to be together while being sober. So right now she has her daughter, who is 7, living with her full time, and her son is staying with her on the weekends, but soon will be staying with her full time as well once school is complete for him. She does have support of her mother and also the significant other's mother, who was actually the foster parent for the children while they were in placement. The goals are to be reunited and to be independently living as a family. Some of the biggest barriers and needs are that she needs to develop structure for her children that are returning home. Specifically, the boy who's returning home has some pretty significant behavioral issues. And then also, it's great that she has the housing out in White Bear Lake, but it is difficult since she doesn't have a vehicle or transportation other than the bus, which makes it difficult to get to appointments and things like that. So I guess the reason I brought this case study was because when I met with her last, her major concern is she's reporting a lot of symptoms of anxiety, possibly depression. She doesn't have that as a diagnosis. She does work with a therapist, but she was very stressed when I saw her. She said she's been missing appointments because she's been so stressed and just has all of these other things going on. And so that's why I brought her case today.
Well, thank you. Let's all give some thought to this, and if you have a suggestion or questions about the case, please unmute yourself and pose them.
I just wanted to know a little bit more, maybe Fallon, if you know more about what kinds of anxiety symptoms she's having and when, or what's triggering those. And also, was she on some medications? Is she on any medications for anxiety, or was she before she was pregnant and she had to take off those?
She's just presenting pretty, just when she talks about her son returning home, how much work it's going to be to get him on a schedule, and you can just tell by her demeanor that she's anxious about it, and she also expresses that. She doesn't have any mental health medications currently. And I did talk to her about speaking with her OB about that, because although she hasn't been on them in the past, so it's not like she found out she was pregnant and quit taking them, but at the same time, always being stressed like that and not being able to make it to appointments isn't necessarily going to be good for a pregnancy either.
I don't know if you mentioned this or not, but is she getting any parenting education or a worker of any kind, or is there availability for that?
They have a parenting coach at Solid Ground, and then she also has a family advocate as well, and then us too. So she has quite a bit of support. So yeah, she does have some of those things.
Dr. Grahan, did you have any kind of input here as far as how we can deal with anxiety as well as all the other issues that Fallon has shared?
I was curious. I don't think after Jesse asked that, I don't think I heard, and pardon me if I missed it, if she had a history of medications or anything that had been helpful for her.
I'm not exactly sure if she's ever been on medications, but I know she wasn't since we've been working together in 2017. So nothing before she was pregnant or anything like that. And I don't know if she has a history of medication that worked in the past or not.
And I know you mentioned both.
She told me that when she was on Suboxone, she felt like she had less symptoms, but then when they switched her to Subutex, she felt like it was a different for her. And I think when she was on Suboxone, she might have been on 32, and now she's on 24 of the Subutex.
Okay. And from your perspective, do you have a sense for, is her anxiety being driven by PTSD or another anxiety disorder? I know you mentioned anxiety and PTSD.
I'm sorry, can you repeat your question?
You had mentioned that she has both anxiety and PTSD, and I was just wondering if you have a sense for, is this mostly driven by PTSD, or do you think she has other stuff going on? I don't know if you have any sense for where the PTSD came from.
I just know she has a history of PTSD. I don't know if that's the significant thing that's happening right now. I think it has a lot to do with all the circumstances, her moving, her having to get the house ready, reintegrating the kids back home, and the pregnancy.
Yeah, she's got lots of reasons for anxiety currently. Yeah. It's hard to just tease that out sometimes from like if she has like developmental trauma or PTSD or kind of her ability to cope in a normal way. So I think I don't remember who was talking about the question about other medications. It's hard to tell what would be most helpful in this case. I think there's definitely some data saying, some really good data, that if somebody's been stabilized on an SSRI like sertraline, brand name Zoloft, or other medications, whether it be for PTSD or anxiety, that the benefit of being on that, if it's helpful, is higher than any risk of withdrawal symptoms or any effect for the kid. Mm-hmm. Zoloft is one of the SSRIs that has never been shown to have any birth defects. Things like Paxil and others have had problems, but sertraline is very safe.
Okay.
Do we have other questions or suggestions with regard to the case?
I guess my only other suggestion would be maybe helping her link her parenting services and her mental health services if the parenting workers would be willing to, and she'd be willing to give access for her therapist to talk with them, because I think they're probably kind of treating this from two different sides, and if they're not communicating with each other, you might miss sort of that her anxiety is being triggered by parenting or parenting concerns, and they can both be working kind of in tandem to help her with that instead of maybe from two completely different spheres. So if she's willing to let her therapist talk with her parenting workers and vice versa, I think that would be really helpful.
Yeah, I think that's a good idea.
Anyone else?
I'm
sorry, go ahead, doctor.
Sorry. Do you know, you said, how old was the kid that's coming home?
The daughter that's already living at home is 7, and then the boy that's coming home he's 8.
He's 8. Do they know, does he have any other reasons why he's such a behavioral challenge?
He's been to quite a few different treatments and things like that already. So I don't know specifically what his behavioral things are, but I do know that he's had interventions for them, and he's in therapy and things like that.
Okay. I was just, sometimes if it's through the school, it depends on if it's year-round or not. So especially if he comes home, just trying to make sure if there's enough other supports that are year-round for him, making sure that she links up with the school district, because oftentimes even if the school district says that the kid needs intervention, they'll oftentimes help find summer support and get some other structure.
Yeah, she actually did mention that I know he has therapies that's going to be ongoing on Mondays, so she does have something through the summer for him.
Yeah, I don't know if he would qualify too, and maybe she's looked into this for CTSS or some other in-home services once he comes back to be with her, that's children's therapeutic services and supports would be really helpful. It's kind of like ARMS for kids, kind of skills work for kids, and sometimes they'll involve the parents in that, which is helpful.
Okay. That's very helpful. Thank you.
Anyone else have some suggestions or questions?
I guess the one other thing that I would say is, it sounds like from your story that she's very worried, and one of the acute stressors aside from like her own treatment care is like the arrival back of her son. Does she endorse having somebody outside of a formal therapy that she can talk to about that she feels safe with?
Like a family support or a friend or something, do you mean?
Yeah.
Actually, one of the things that I did forget to mention is that she was very active in NA and had a lot of support through NA connections, which she could talk to about her different things too. However, since she's moved to White Bear Lake, she hasn't been able to get reconnected. So that is one of the recommendations that I had for her, to try to get connected with an NA group, and hopefully she can find somebody that has similar things as her going on with her family and things like that. She does have a mom who is supportive, and then the mother of her significant other who had the children before, while they're in placement, she also has a close relationship with.
Well, Fallon, do you have any specific questions for people on the call that might be helpful to you, or are you feeling like you've had some input that's going to be helpful?
I feel like I've had some helpful input, and I really appreciate it.
Good, good. Well, we're nearing the end, and I want to just quickly ask, did anyone have any other further questions regarding the presentation from Dr. Grahan?
I do have one more, if that's okay. You talked a lot about that someone, I think you were talking specifically about methadone, shouldn't be exhibiting symptoms of sedation or nodding out, those kinds of things. We often do see things like that. So what do you make of that when a treatment provider maybe is saying we're seeing some kind of reaction, and this might be for methadone or Suboxone or other medications, and how can we best work with their prescriber when we have those concerns?
Yeah, great question. I would say I would hope that the patient would sign a release that you can talk to their treatment facility, their opioid treatment program. Usually the way that it's set up in an opioid treatment program is that most of the decision points are primarily driven by the alcohol and drug counselor, who then takes that concern to the prescribing physician. So I would strongly advocate in that case just making sure that they hear that you're getting sedation and when. Especially if it's longer than like 2 hours out after the dosing, then that's probably more than the patient needs, and they're treating other symptoms. Or they're probably treating anxiety and or depression, because it's probably more than they need. I think it's hard, though, in many places advocating that they should go down the dose, and this is just the culture of many opioid treatment programs, is if a patient's had a history of relapse, that just means more is better, which is not necessarily true. As you guys know, there's lots of reasons for relapse and triggering, but just the culture of it, I think it's just good to be mindful of. So I would try to get a release of information, talk to them about sedation, and oftentimes it means going down by 5-10 milligrams just as a trial, and maybe even more. But most people, this is a population average, most people find that they get extinguishing of cravings and of withdrawals by like 90 milligrams. So when people get up to like the 150s, 180s, usually they're treating something else with their methadone.
When you're referring, I have a question as well. Mm-hmm. When you're referring to a client shouldn't be nodding out and things like that, are you referring to once they're on a stable dose, or how is that different during induction? Or is it different?
Induction, usually, if they're during induction, if they're already nodding out and they're still going higher, then that's probably an issue. Or you'd wonder, are they using other opioids on top in order to get to some? So oftentimes people may be nodding out if they're on like 60 of methadone and they go out and they use because they just feel like it's not quite right enough. And then you kind of get the additive effect. So I think that's the challenge of the induction period of like, when do you start extinguishing that? That's where usually the withdrawal symptoms are almost always gone by 60, max 80 milligrams. You should never see somebody that has acute withdrawal symptoms on like more than 80 milligrams. People will complain about it, but it's not, unless they started another medication that changes the metabolism of methadone, it's not the methadone. It's something else that's going on with them. But the cravings and kind of the other discomfort, that goes back to the anxiety or whatever else are they feeling. So if you start seeing, like, if they're on a stable dose and it's like a new sedation, then I'd say, do they start taking another medication that changed the metabolism, or did something else happen in life that's disrupting their sleep? But if they're still on induction or they're a dose fluctuation, they're going up and they start seeing sedation, that probably means they need to cut it off and go back down a little bit.
Great, thank you so much. Well, we've got about 4 minutes left and I want to wrap things up. Please, Sarah will be sending out, excuse me, the evaluations. We didn't get any last time, so please take a moment or two to check your email and complete the evaluation, send them back to Sarah. That's very helpful to us. It looks like everyone is signed in and we're good with attendance, Sarah? Okay, good. If this has generated some questions or you'd like some more specific information on medication-assisted therapy, you can please email that back with your evaluation, because we have a wealth of knowledge and we are in all around us, and we want to bring that in and share it where it can be most useful. So if you think of whether it's medication-assisted treatment or any topic that you'd like to talk about, we will continue to ask and hope for your input, because we want this to be something that's useful for everyone. You can invite your colleagues to join us, and we're happy to put them on the notice so that they get the link. And just, again, that's a quick email to Sarah or to me. And think about whether you want to volunteer to present a case. It's not too hard, right, Fallon? Not too hard to present a case?
It's not as bad as I thought it would be.
Well, good. That's good to hear. And it's very helpful to have a context for our discussion. So please think about doing that. And then know that next time we meet, we aren't going to meet in July because it comes right in the midst of the July 4th holiday week. We are going to meet again August 7th. And on that day, we are looking at ethics in substance use disorder treatment. And Carmen Finn from Wayside will be our didactic or lesson presenter. And again, we want ethical issues. If you've got some questions, please let us know and we can walk you through. Even if you're not sure how to fill out the case form, we'll help you with that. Does anyone else have anything else they want to add before we wrap it up?
Just one thing that I would comment, sorry, this is like a comment that I just forgot to mention, but for Fallon, for patients with bad anxiety, especially when things are coming up, oftentimes if they have a history of PTSD or other traumas, one of the first things that goes is their sleep. And when you have bad sleep, psychotherapy for anxiety doesn't really work. And so it's just a really important thing that I always ask about for patients with bad anxiety, period, but especially in that context, is if she's struggling with sleep, that's probably the first and foremost thing to focus on, or especially get her directed help with, whether it be a medical provider or CBT for insomnia, but really working on sleep first, because with bad sleep, nothing else is really going to help. So whether that be PTSD coming back, Prazosin or brand name Minipress is safe in pregnancy. Melatonin is also often safe, although the key to melatonin is you have to take it at a specified time every night, which with kids sometimes that's difficult. Mm-hmm. But I think it's something to explore.
Okay.
Great. Thank you so much, everyone. And we'll look forward to seeing and hearing from you all again in August. And do watch for the email from Sarah and complete your evaluations and share with us the ideas that you have for future ECHO sessions. Have a great day.
Thank you. See you later.
Bye.